we are live, and maybe good morning, maybe good afternoon, maybe good evening, depending on where you are logging in around the country or world. I want to welcome you to today's VETgirl YouTube live event. Very excited to have Dr. Christine McKinney here today. We're going to be talking about the evolution of allergic dermatitis treatment in dogs, the now and the next. And oh my goodness, we can see in the question screen already, we have our common stalwarts that are with us today. They know what to do, but let's let everyone else know. My name is Garrett Pachtinger. I am the VETgirl co-founder and a board-certified critical care specialist. And I am logging in from kind of gray and cold Pennsylvania. And I'm very excited. I think this may be her first with us behind the scenes. We have Dr. Amy Kaplan with us, another one of our VETgirl team members. Dr. Kaplan, a criticalist. Where are you logging in from today?
Hey, everybody. Yeah, so as Garrett said, for those of you who haven't heard my voice on a webinar or a podcast yet, my name's Amy Kaplan. I'm a small animal criticalist, and I'm logging in from sunny but pretty cold Omaha, Nebraska.
All right. And Dr. McKinney, where are you logging in from today?
I am just outside of Boston, Massachusetts.
Wow. And I promised Dr. McKinney we would have an awesome, well-rounded global approach, and you guys are proving me right already. I'm looking at our question screener. If you can type in where you're logging in from, we already have Portugal, Vancouver, Germany, and Minnesota in the mix. So please go ahead, keep typing in where you're logging in from around the country or world as we go over our housekeeping slides, and I'll recognize a couple of other areas in a little bit. But I did want to give a huge shout out and thank you to Merck Animal Health. Many of you know they've been an amazing educational partner for VETgirl over the years, one of our oldest educational partners. And it's with their generous support that we're able to provide this VETgirl YouTube live event completely free, race approved, to anyone that would like to join. Northern California, who else? New York, keep going, we love it. As I said, this is race approved, so how are you going to get your race certificate? Two different ways, and Justine, who's behind the scenes, is going to type this into the question screener, but one of two ways. You can use your fancy smartphone and that QR code, or type into your browser tinyurl.com/VG, for VETgirl, of course, VG, and then today's date, 12/4/24. This event goes from 12 to 12:30 approximately Eastern. We're going to keep this questionnaire, this race-approved form open until 1 p.m. Eastern, 30 minutes after the session is over. So please, before the session is over or within that 30 minutes by 1 p.m. Eastern, please fill out this form to get your CE certificate. Others, Davis, California, Florida, Seattle, Maryland, Minnesota, Indiana, Maine, keep going. We love knowing where you're logging in from. As this is a YouTube live event, we know sometimes it's a little bit smaller depending on what device you're looking for. So please find that button, which makes it full screen so you can see our pretty faces in HD, high resolution, as big as they can be. You're not going to want to miss Dr. McKinney's awesome information. A couple more housekeeping slides here. If you're not familiar with VETgirl, we are the tech-savvy way to get your online education. We have a multidisciplinary approach, whether it's a webinar, a YouTube live, a podcast, a video, a blog, our certificate programs. We know people learn in different ways, and we give you that opportunity to learn the best way that's suited for you. Check out our content. We offer over 150 hours of new content every single year, and everything we do that is or was live like this will go into our on-demand library, so you can watch it 24 hours a day whenever you want, 2 a.m., 2 p.m., whenever it's convenient for you. We want you to have the opportunity to learn really at a very cost-effective price, whether you're an individual that signs up or you come online with our discounted team plans. It's a great way to get education whenever you want, around the clock, whatever's convenient for you. We also hope you have attended. If not, you're going to attend one of our upcoming in-person live conferences. This will be, I think, our 5th or 6th now. It's going to be in the amazing Nashville Music City at the Renaissance Hotel. I've been there now a couple of times. It's one of my favorite places to be. You're going to be in the middle of everything. This sells out every year. In fact, we had over 500 people on our wait list last year, so don't delay. If you have CE money left over for the year, use it or lose it. Sign up for our conference and join us to get some amazing CE in Music City with us in June of 25. With that said, I know you're not here to listen to me and Dr. Kaplan's better than me, and you're not even here to listen to her. We want to hear about derm and from Dr. McKinney. So Dr. McKinney, we're going to drop ourselves out of the frame in a little bit, but if you can give our audience a little bit of a background of who you are and then what you love to do, and then please take it away. Thank you so much for being here. The floor is yours.
Yeah, so thank you guys for hosting. I'm super excited to talk to everybody today. So I am living outside of Boston. I've been in private practice here up until joining Merck this fall, but I am a Texan by birth and went to vet school at LSU. So if there's any Tigers here, but yeah, I've been in New England here since starting my residency at Tufts in 2014. So I am super passionate about veterinary dermatology, and I love talking about this. So I guess let's get started. We have a lot to cover. I will try to keep this really tight. I could certainly go on about this stuff a lot. What we are going to talk about today are really the different kind of drug options that we have to manage allergic dermatitis in dogs. And I want to start thinking about a couple of things. So I want to start thinking about how can we utilize this information to make more individualized decisions about what treatment may or may not be the most effective for that particular patient. You know, one of the things that I think we've all known, and if you're in practice, you've seen it, but we are certainly understanding it more from like a true pure science perspective, is that allergic dogs do not all have the same combination of cytokines and inflammatory mediators, right? So there's all of these, like, there's a lot of individuality to this, and that means that we have to think about our therapeutics in that way too. The other thing that I want to talk about is just looking towards what the trends are on the human health side, because as we all know, that's probably going to inform what's going to happen on our side in the future. All right, so just for the purposes of this lecture, when we are talking about allergic dermatitis, we're really talking about dogs that fall into these three buckets. Most of these guys are going to be atopic, but you may be dealing with some flea allergies or some food allergies as well. I would be remiss if I didn't mention as a dermatologist that allergy management is multimodal, right? So these drugs do a really good job of controlling the pruritus in most cases, but even the best drug is going to be less efficacious if we are not also managing these other things in conjunction. So once upon a time, right, we had steroids and antihistamines in immunotherapy, and we still have access to these things. Immunotherapy is a treatment, it's not a drug. And I would argue that steroids and antihistamines are two sides of a coin, where steroids have really broad targets. They hit these targets too and affect these targets in a lot of different ways, which is one of the reasons they're so stinking effective for managing allergic dermatitis. But that also means there's a lot of side effects. Antihistamines, on the other hand, are pretty targeted, right? So they are just going to really affect histamine release, pretty well tolerated in most dogs, but just not really efficacious. Then we kind of moved into this era of cyclosporine introduction, which was certainly a step forward. And now we're entering and have been kind of living in this more modern age where we're dealing with oral JAK inhibitors and monoclonal antibody therapies. And that is certainly mirroring what's happening on the human health side as well. So this is just a little quick illustration that is a tiny little window snapshot of potentially what's happening in any itchy dog. And I show this not because you need to know these things, but just to say, okay, well, you have histamine here on the left being released by a mast cell. If you take that out, there's still all these other things that could be affecting an itchy dog. Same thing with IL-31 on the right. You know, anti-IL-31 therapy is far more effective than antihistamine therapy, but I think we've all experienced sometimes it's just not enough, or maybe they don't respond at all. And so again, it's this idea that every individual is going to have their own proportion of inflammatory mediators and cytokines. And so how can we best work with that particular individual? So cyclosporine is a calcineurin inhibitor. If you're not kind of familiar with this class of drugs, calcineurin is this little white circle over here to the right. And it is part of a pathway that essentially turns on IL-2 production in T cells. Now, T cells are, as we know, the driver of allergic dermatitis, and IL-2 is a T cell growth factor. So if you are reducing IL-2 production, you are reducing activity of T cells. Now, you'll notice I didn't say eliminating IL-2 production because this drug works in a really dose-dependent manner. So when we are using it to manage the allergic inflammation, right, we're using it at about 5 mg per kg per day for a dog. That is a lot different than if we are using it at 10 or 15 mg per kg per day. Like my criticalist friends here might use it for a dog with IMHA. So this drug, is going to work on kind of a spectrum depending on the dose. I actually really like cyclosporine. I'm a big cyclosporine fan. I think it gets knocked a lot, but it's actually really reliable. Most dogs will respond, but that is not a fast process. This is going to take time. One of the real benefits that cyclosporine has over some other therapeutics is that most of these dogs, or a lot of these dogs, don't necessarily have to take it every single day, which can reduce certainly the overall cost to the client and reduce the risk of side effects. I really like cyclosporine as a good choice for dogs that have really highly inflammatory disease or hyperplastic disease, right? These dogs that have really hyperplastic ear canals, these furunculosis feet, cyclosporine in a lot of those cases is really a superior choice. And that makes sense because when we are working, again, in a more broad fashion, cyclosporine is not going to just pick the allergic T cells and affect those, right? It's going to work on all T cells. And so when we're doing this on a more broad level, we get that more broad anti-inflammatory control. And that's what these dogs really need to get better. The cons, obviously, are this kind of broad activity tends to come with more side effects. So you can see a theme forming. In some dogs, it is limiting where they just can't tolerate the drug from a GI perspective. A lot of dogs will adjust to it after a couple days and the GI side effects are really mild, but that's the most common one we see. These other side effects are actually really uncommon and happen in a few dogs. But when they happen, again, sometimes it necessitates discontinuing the drug. One of the more practical issues with cyclosporine are drug interactions. So we see stuff like, interactions with maybe fluoxetine or phenobarbital. That does not preclude using cyclosporine. It certainly can be done safely, but you might choose to monitor those pets in a different manner. All right, so this is kind of shifting us into, like I said, that modern age where we are going to be using a lot more oral JAK inhibitors and monoclonal antibodies. So we're going to start here. So monoclonal antibodies are usually IgG molecules that have been engineered for one very super specific target, which confers usually a lot of safety, depending on what that target may be. These guys are just immunoglobulins, and so they are proteins. And so they're going to be degraded as proteins and recycled as amino acids. And so you are bypassing a lot of body systems, right? You're not worried about GI absorption. You're not worried about hepatic metabolism. But caveat is they have to be injectable. So we have one in veterinary dermatology, which is Cytopoint. The molecule name is lokivetmab, and that's manufactured by Zoetis. So Cytopoint binds circulating IL-31. And IL-31, as far as we know, in dogs is simply a paritogen. So this is just going to make dogs feel itchy. In humans, they have nemolizumab, which is also an anti-IL-31 therapy, but it acts at the receptor, not the circulating cytokine. I mentioned dupilumab here. So dupilumab is a monoclonal against the IL-4 alpha receptor, which is shared between IL-4 and IL-13. And this treatment has been really revolutionary, I think, and really dramatic results in human medicine, especially for children with pretty severe eczema. And I say that again, just to kind of think about what are some potential exciting targets that we could be thinking about from the veterinary side. This class of drugs in general tend to be really safe, well tolerated, really few contraindications. I would consider Cytopoint probably the most targeted treatment that we have available to us in veterinary dermatology. Now, the trade-off here is that when we are selecting one single target, that means we're not hitting the others, right? So for these dogs that need that anti-inflammatory support, that have a ton of visible inflammation, that have tissue architecture change, that have tissue hyperplasia, the expectation for me is that this might make them feel a little less itchy, but it's not going to address those problems. And so this maybe is not the best or first or only choice for those dogs. I would see in practice, quote unquote, a lot of Cytopoint failures. And I don't think that that's necessarily a failure of the drug to do what it is supposed to do. I just think that those dogs that had that hyperplasia, that had that inflammatory component to their disease, I think it's just an expectation of what we really can expect or the limitations of this treatment. So on that right side, if we go back, there we go. So the Colorado State study I just mentioned because I thought there was a super cool finding that they had, which is that dogs that did not respond to twice daily dosing of Apoquel were less likely to respond to Cytopoint. And to me, that is just lending evidence to this idea that IL-31 is not going to be the main driver for every dog's atopic dermatitis, and that all of these dogs are gonna have some individual mix that we need to address. So that brings us to talking about oral JAK inhibitors. So not to totally age myself, I already did, but I didn't learn about the JAK-STAT pathway in vet school. I certainly didn't learn about JAK inhibitors. So we're going to spend kind of a chunk of time just talking about what these drugs even are and what this pathway even is. So the JAK-STAT pathway is basically just a highway. It's a way to get a message from one cell to another really quickly, with the end game being that we are turning on transcription of a particular gene, right, or protein. Dysfunction of this pathway is really implicated in a lot of inflammatory and immune-mediated diseases. And so this class of drugs tends to be really appealing for managing a lot of those. So like in people, psoriatic arthritis, ulcerative colitis, they use a lot of oral JAK inhibitors. There are three main components to the pathway, and usually these guys exist in pairs. So you'll have a pair of receptors, a pair of JAK enzymes, and a pair of STAT proteins. So you have receptors, and these are going to be the guys that have an extracellular and an intracellular portion. And that's where whatever the hormone, cytokine, interferon, interleukin is going to bind. Then you have two JAK enzymes that are going to be inside the cell. You're going to have two STAT proteins that are going to be inside the cell. So you see, okay, well, we've got 4 JAKs. We have 1, 2, 3, and TYK2, and we've got 7 STATs we know about. But we know that there are at least 50 different cytokines that utilize this pathway. And so there is a lot of redundancy in this system. There's a lot of like collateral circulation, if you will. And so cytokines are going to preferentially utilize a particular JAK enzyme, or they're going to utilize a pair that they like the most. But at a certain point, they may utilize other pathways. So these guys are everywhere in the skin. They exist at all layers of the epidermis. They exist in the dermal inflammatory cells. And we know that IL-31 utilizes the pathway in the nerve endings to transmit that sensation of itch. So this is how this pathway works. So you have this little gray triangle at the top that is, let's say, your interleukin that's binding the receptor pair, which induces a conformational change. And these receptors are going to move closer to one another. That is going to signal 2 JAK enzymes in the cytosol to come associate with the tails of the receptors. And those guys are going to be activated by phosphorylation. So there is a phosphate group being pulled from ATP and put onto these JAKs, and that's going to turn them on. They will then add phosphates to the tails of the receptors, and that's going to signal two STAT proteins to come in and associate with that whole complex. The activated JAKs will then in turn phosphorylate the STAT proteins. That is the signal for the STAT proteins to dissociate. Those are going to come together to make one molecule. So it's a dimer. Again, everything's in pairs here. And that moves to the nucleus, and that is what turns on target gene transcription. So when we're manipulating this pathway, we can do it at a couple different places. So the image on the bottom right would be how cytokine works. It is neutralizing that circulating ligand. The bottom left would be where nemolizumab works. So same pathway, it's just blocking at the receptor level. Now, oral JAK inhibitors are going to be this top image, which is they're basically going to fill this physical binding pocket on the JAK enzyme where that phosphate molecule would normally go. And so it blocks that activation of the JAK, which means that everything downstream from that stops as well. So on the left, the ones in bold, which they don't look super bolded here, but that's fine. These are a lot of cytokines that are really involved in the acute allergic response in atopic patients. And you'll notice the commonality here is they all like to utilize JAK1. So if we are choosing an allergic JAK, quote unquote, JAK1 is going to be the guy. On the right, you'll notice that the commonality here is that these all utilize JAK2. And with the exception of growth hormone there, these are bone marrow related, right? So we've got erythropoietin and thrombopoietin and granulocyte monocyte colony stimulating factor. And so when we are designing therapeutics or choosing therapeutics, right, we want to, how do we target that dysregulated portion? How do we target that disease without affecting the things that are critical for life? So this opens the door to talk about this concept of selectivity. And the definition of selectivity is simply a measure for how sensitive an oral JAK inhibitor is to bind one JAK enzyme over another. So first generation JAK inhibitors at a therapeutic dose will bind multiple JAKs. Maybe they do that more strongly for one than another, but we know that they'll bind multiple. Second generation JAK inhibitors at the therapeutic dose will only bind one JAK. Now, I think that it is reasonable to assume that, like I mentioned, there's a lot of redundancy in this system. And so at a particular dose, I think it's reasonable that even the most selective of JAK inhibitors potentially will spill over and utilize other JAK enzymes. However, the idea behind increasing selectivity and creating second generation JAK inhibitors is that you are widening that margin between that therapeutic dose and the place that that might happen, right? So how can we give ourselves a bigger cushion where we're targeting, again, the disease and leaving everything else alone? So we're going to zoom past that slide because for timing's sake. Okay, so this is what's been happening on the human side. So we now have development of second generation JAK inhibitors where upadacitinib and abrocitinib have come to market with approval for treatment of atopic dermatitis in humans, and they are JAK1 second generation selective JAK inhibitors. And the idea, again, is if we can target that disease and leave everything else alone, we are hopefully going to minimize the risk of adverse events. And in people, you know, I think that, like, this is the human list, but I think there's some good analogs for potentially stuff we might deal with in dogs. So they worry about shingles virus reactivation. Maybe for us, that looks like papillomavirus. If they're worried about non-melanoma neoplasia, maybe for us, that looks like histiocytoma development. Certainly these things in the center columns are problematic for any species. And it's, you know, as a general class, oral oral JAK inhibitors tend to be well tolerated and really safe. And I think that we, for the most part, as a field, have experience with that. And so I want to start thinking again about the individual, right? So how can we, now that we're getting more options, right? What is the individual risk and how can we reduce that risk for any individual? Because I would love to be able to look at a dog and be like, hey, you're going to be that one that has the idiosyncratic reaction. You're going to be the anemia dog. You're going to be the papilloma dog. But we can't know that. And so this trend towards creating more selective drugs is, again, making it safer on the whole, but also making it safer on an individual level. So this is a pretty short slide because we just have 2 of these available to us. And we have Apoquel, which is oclacitinib made by Zoetis. And we now have Zenrelia, which is ilunocitinib, manufactured by Elanco. We do have some preferentiality, selectivity data from Zoetis about Apoquel. We don't necessarily have that yet for Zenrelia. But both of these would be considered first-generation non-selective JAK inhibitors. Pretty similar indications as far as label goes and age. The big, noticeable difference with Zenrelia is the black box warning around vaccine timing. So when we're choosing JAK inhibitors for patients, they are excellent antipyretic medications. They are going to fall somewhere between Cytopoint, which is, I think, again, like a purely antipyretic, and Cyclosporine, which is a much stronger anti-inflammatory. These guys are definitely going to have anti-inflammatory action, but it's not going to be as much as Cyclosporine. So that's all I have for you guys today. This is my dog Crackers, who is not atopic yet, as far as I know. So fingers crossed he stays that way.
All right. Hopefully everyone can hear me again. I brought myself and Amy back. Dr. McKinney, awesome information. Really appreciate it. Super sweet pup, by the way. Always, who doesn't like seeing a sweet pup at the end of a presentation? That's what we're all here for anyway, right? And Dr. McKinney, I don't know if you want to talk about this slide as well.
So Merck Animal Health is committed to bring innovative solutions right to the market, and dermatology is an expanding field. And so if you guys want to be on the list, to be first to know about any innovations that we are coming in with, regardless of whether it's derm or vaccines or anything else, scan and get on the list.
Awesome. Thank you so much. And as I said before, a big shout out to Merck Animal Health, and I'll bring this slide back in a second, but they've been one of VETgirl's oldest educational partners since the beginning with us, and really thank them for allowing us to provide this awesome information, race approved, free to the veterinary world. So thanks both to Dr. McKinney and Merck Animal Health for allowing us to do it. Such important information because, Amy, I'll speak for myself. I know sometimes when Justine's here, I joke, there's no derm emergencies, but we certainly saw, as Amy and I are both critical care ER people, tons of derm cases. And I don't think you get it. Justine actually makes the comment often, until your dog is next to you itching at 3 o'clock in the morning and can't settle, and now everyone can't sleep. We get it. I mean, no, it's maybe not the same type of emergency as everything else, but it doesn't make it any less important. In fact, this is such an important topic for, not only disease perspective, but for quality of life for our patients. We know how important that is for our patients. So such great information. And Dr. McKinney, as you were talking, I was thinking to myself, wow, I'm going to really date myself here. I feel like when I was in veterinary school, it's like you itched, you got prednisone.
Mm-hmm.
Like, that's what it was. And now to see, I graduated veterinary school from the University of Pennsylvania in 2005, and almost 20 years ago now, and to see all the new changes and advances, not just that there's cool drugs that are available, it's just they're cool, they're effective, they've become safer. And the patients have such a better quality of life without the side effects of some of the other drugs we used to use. To me, it's just so incredibly remarkable to see all these amazing things that have happened. And while we're bantering, I did want to remind everybody, I'm going to bring the slide back up now. Please remember, we'll have this open for another 30 minutes. So you still have 30 minutes, but if you've not used your fancy smartphone or use that URL, the website address, to enter your information, for your CE certificate, please make sure you use the email address associated with your VETgirl website account. That's how we match your CE certificate to your account, which will be found in your My Credits page. And if you don't have one already, which you probably do at this point, it's completely free, and we even give a 14-day trial membership. So please make sure when you fill out this form, you use the email address associated with your VETgirl account so we can get you your CE certificate. With that said, please go ahead and type in any questions that you have in the questions screener. I'd love to read a couple. I know Justine's behind this the scenes. She wrote Temerol P. Yes, the old Temerol P that we used to use as well. We certainly, I'm going to be the first to admit, have I prescribed or recommended an antihistamine like diphenhydramine for a dog in the past? I did, but that's before somebody like Dr. McKinney said, Garrett, antihistamines don't work in dogs so much. And so, we learned so much over the past almost 20 years now, at least from my standpoint, that it's really, really cool to see some of this stuff. All right, let's see. What other questions do we have? Let's see. Please go ahead and type the questions. I know someone did write in here. Do you have experience, pros, cons, contraindications? You talked in the beginning about cyclosporine. We also talked a little bit about drugs like Cytopoint. Can you use those together? Are there things we should watch out for? Do you not? Do you recommend? What are your thoughts on those two drugs together?
So I frequently have used this together. And as far as we know, they're safe to do so. I have used Cytopoint in combination with Apoquel as well. Again, there's no drug interactions, and these are working on really two different, totally different parts of that allergic pathway or what might be happening in the disease. And so sometimes dogs do, like the more refractory cases will need multimodal therapy, and sometimes that looks like two medications. So as far as we know, those are absolutely safe to use together.
Excellent. Thank you. All right. And someone asked, I didn't even know this existed. I'm just trying to do some research so I don't sound. Is there an Atopica collar that is available now?
There's not. And I think they might be asking about a product called Atopic, but if
that's
they
what
want
I Googled, and that's what came up. So I want to make sure I wasn't silly about this, but when I searched that, that's the first.
If only.
Yeah, that's the first hit that I have. So maybe it looks the same, the initial word, but it is not the same. And
if Atopic is what they're referencing, I love these. Whether it's the collar or the spot-ons, these are going to be products that essentially are helping repair the skin barrier, which we are now knowing to be a huge part of the pathogenesis of the disease. So whether it's this particular product, there's more and more kind of coming out. They're absolutely an excellent addition. I would not expect that they're going to control a dog alone, or at least not somebody that doesn't have like really mild disease. But absolutely love this idea.
Yeah, you actually hit the nail right on the head. I mean, right on their website, that's what it says. And I just wanted to make sure, as a silly critical care guy, I wasn't missing out on something new and cool it was invented. Because, certainly we do understand that some pets will tolerate injections, some will tolerate medications orally, and then there's some that are more challenging in different ways. And so just wanted to make sure I wasn't missing something that was neat and on the market. If there are any other questions, please go ahead and type them into the question screener again. Please go ahead, if you haven't already, and fill out this form. And I also wanted to bring back this QR code so you can be in the know, be one of the first to know about all the cool products that Merck Animal Health is coming out with, all the new innovations, because clearly we're not just in the Temerol P prednisone market anymore. We have much more effective, safer medications out there that, as I said before, are just so great for the quality of life, because we understand that quality of life is one of the most important things for our pets and our patients that families care and worry about. And I clearly remember, you get a dog on a steroid, and within 72 hours you get that call like, what else can we have? My dog is counter surfing. They're drinking all the water in the house. They're peeing all over. I can't take this anymore. And so if we can get them on not only safer but more effective medications, even better. Well, I don't see any other major questions that are coming in. We're a few minutes over our event time. Again, thank you so much to Dr. McKinney as well as to Merck Animal Health for all of this awesome information and this event. I hope you have the opportunity to go to that QR code and to fill out that form for both your CE credit and to be in the know. This will be on our VETgirl library as well as YouTube. So if you want to review it at any time, you certainly have access to do that. And again, thank you everybody for all that you do. I know my hope is, and I'll bring up the C word, COVID is sort of behind us, but what isn't behind us are the number of pets that are in houses now. We all know you are ever increasingly busy. And so thank you for all that you do each and every day. Sometimes you do get the accolades and recognition, and sometimes you just feel like it was too busy of a day, but we recognize that you are all amazing, amazing people, and what you do really, really matters. So we hope to just be some small part of that in your educational life cycle. Thank you for all that you do, and we hope to see you online at our next VETgirl event, or maybe at VETgirl U in Nashville this year. With that said, have a great rest of your week, and thank you so much, everyone. Bye-bye.